Have you got most of them admitted, Jer?
They're coming in still.
Okay, I'll just give it a couple of minutes to let everybody join, because I can see the numbers on the screen shooting up here. Okay, good evening, everyone. I think there's still a few being admitted, but we might as well make a start anyway. First of all, thank you for joining us tonight. And just a few points before we commence. I think quite a few have probably joined us before. So it's the usual format. Any questions, just use your chat button and type them in, and we will ask the questions at the end. And please, if you think of them as you go along, please put them in as you go along rather than wait until everything's finished. It gives us time to organize ourselves. First of all, this is the last webinar we're going to have now before the summer break, because I think as the evenings get longer and hopefully the sun will be shining, you'll probably have other things to do than sit at your computer. So to the business in hand, we're very fortunate to have Lisa McAuliffe do the presentation tonight. Having started her career as a veterinary nurse, she very quickly progressed to take her veterinary degree, qualifying in Liverpool in 2003. She's worked for 5 years in small animal referral hospitals in the UK, then joined us in Ireland, where she completed her RCVS Cert Opthal, I might pronounce that wrong, in 2009. Then she also, in her spare time, which I imagine there wasn't much of, was the first person to obtain a master's degree in anesthesia and analgesia at the University in Edinburgh in 2019. She worked for several years with referral ophthalmic clinics in Cork. And then in 2018, she branched out on her own and established the Pet Eye Clinic in Middleton, specializing in ophthalmic referrals from all over the country. I'd like you to welcome Lisa tonight, and I'll hand over to you, Lisa.
Thanks very much, Anne. Thank you. I've got no spare time after listening to all
that. After I read it all.
And apparently I have a husband and 2 children too, and some sheep. But thanks very much. And thank you very much for inviting me along tonight to talk about what is my favorite subject, ophthalmology. I'm going to share my screen now. Bear with me while we have a little look. Share. And I'll pop you onto the slideshow. So feel free as we go along to ask questions if something, if I stimulate a question from something we discuss. And in trying to select subjects to talk about with ophthalmology, the subject is vast. And even the last few weeks doing webinars for some vets, we spent a whole evening talking about the 50 shades of red, which was just reasons that you can have red eyes, and that was 3 hours long. So this is much condensed into probably the most common situations and disorders that I see in animals. And what do we see? What do we look at? So I look particularly at all species. We do cats, dogs, look at lemurs from PHOTA, look at horses, and more recently my own sheep. But we see all species as ophthalmologists. We don't just concentrate on small ones. And in doing the older certificates in ophthalmology, we had to do comparative ophthalmology. So we look at all species and all syndromes. And as we go through some of the slides tonight, and a lot of them, if you are squeamish, I hope everybody can cope with them. But there are some close-ups of different conditions. And different conditions in different species can look different. So we have to be able to recognize that in all species. When we're examining them, we're looking, when you bring your dog or cat for an ophthalmic exam, we're looking right from the front part of the eye through to the back part, to the retina. And when I say front, I mean tear film. So we look particularly at what the tear film is doing. And then the cornea, which we describe as the windscreen of the eye, the anterior chamber, the lens, the pupil, the iris, and then the posterior segment, which you can't really see until you dilate an eye and have a look. And I'm sure most of us have been to the opticians or ophthalmologist, and they put drops in your eye to dilate up so that you can see the back part of your eye. And we're looking at all of that from front to back. And we look at old patients, young patients, and everybody in between, because anyone can present with either a congenital problem, something they've been born with, or something that's acquired along the way. And who do we see? Well, I see mainly small animals, so different breeds. We've got the brachycephalic breeds, which probably present more than any other breed. So that's the Frenchies, Lasses, Apsos, Shih Tzus, Pugs. These guys are ones which we tend to see all the time on a regular basis because of the problems they have with lag ophthalmos, which means that they're not blinking properly. And this poor chap here on the left, you can probably see he's got lots of sclera, the white of his eye on display. He's got a strabismus, so his eyes are pointing in an odd direction. This is normal for him. He doesn't have a particular impairment, but unfortunately, his brachycephalic nature and over time, unfortunately, breeding has contributed to some problems that he now has. And so he's got ocular problems, which are acquired along the way, but we do see lots of brachycephalic breeds with issues like this. Then we see the large breed dogs with a completely different set of presenting signs. Bernese, I've just popped on there, was one of the ones I've been seeing a lot of lately. They've got other issues with their lids, as you can see, the upper and lower lids there, and they can have ocular discharge because of it. We also see lots of cats. About 90% of the worldwide population of cats has feline herpes virus, and they can be either carriers or they can be symptomatic and shedding. And so I see an awful lot of cats with feline herpes virus symptoms that cause ocular disease, discharge, and ocular pain. We'll see some photos along the way. And then there's a more common breeds, let's say Labradors particularly, and Cockers. But we see pretty much anybody, anyone. It doesn't necessarily have to be a breed that's recognized gets an ophthalmic problem. And when I take them in to do an examination, what am I looking at? Well, we start with vision and neurological tests. That's the early part of my examination of a patient. And you can get a lot of information from how a patient walks in the room. If they're a dog or if they're a cat, you pop them up on the table and you might watch how do they behave. Just with no instruments at all, you can tell if somebody's very anxious and cowering, literally dancing along the floor, sliding along the floor, instead of actually wandering around and actually visibly looking. So vision is easy to assess without actually picking any instruments up. Neurologically, there's three things that we look for in a patient, but only one of those tells us whether or not a patient can see one of those responses. And we do that to begin with before we do anything else. And then I'll look at the tear film, like we were saying, dilate up a patient and then look at the back of the eye. But we do each patient systematically so that we don't miss anything along the way. And each patient gets the same eye exam, no matter whether or not they came in for a thorn sticking out of a piece of conjunctiva, or if they came in because they're losing their vision. It's important not to miss anything else along that path of diagnoses. We look at discharge, and we'll go through discharge in a minute. There can be different types of discharge from eyes, some which mean nothing at all and others which can be quite sinister. We look if they're painful, and there's lots of different symptoms of ocular pain in animals, pain that you maybe didn't expect to see. The chronicity of something, how long has it been there? Has it been something that acutely happened when it ran onto a briar and it was fine yesterday morning, or has it been worsening over a period of time? And then what response to treatment has an animal had prior to coming to see me? Because often these are referred patients, so they've often had some degree of intervention before they've been. Has it been positive? Are they just the same, or are they actually getting worse? So hopefully here's the first one. Not so gory eyes to put everybody off. Ocular pain in our patients can be demonstrated by a few things, and this is a dog who had uveitis, that's inflammation inside the eye. So not really that much to see on the outside. You can see the whites of the eye there are red, and you might mistakenly maybe think that this is something like conjunctivitis, but actually when you look inside the eye, the iris itself is a little red looking, swollen, it's muddy, and things just aren't clear. But this is a patient who was really head shy. They didn't like you going anywhere near just that side of the head, near the eye. Dogs, particularly if they're friendly and they want to sit up on the couch with you, they'll take themselves out the way, they'll isolate themselves, and they don't really want to interact sometimes, particularly if they've got a condition maybe like glaucoma where the pressure inside the eye goes up. So you'll often see just very subtle behavior changes with our small animals rather than it being an overt eye closed. But another of the things we see is blink rates. Sometimes the eye might be closed a little bit, might be winking at you a little bit more than the other side. And there may or may not be discharge, might be clear, might be purulent looking. And there may or may not be vision. And when animals lose their vision, it doesn't necessarily have to be in both eyes at the same time, at the same rate. So they might be bumping into things on one side, not on the other. And these can all be signs of different conditions. So that's where we come in to try and work out what it might be. But they can happen at different rates as well. And this is where we get to talk about discharge. Well, discharge can be clear or serous. It can be mucoid. I like to think of these as more like stringy eye bogies as you try and remove them. And it can also be mucopurulent. And this chap here, this is a photograph of a West Highland White Terrier who has, you can see this sort of crusting ocular discharge around the lids there, and sticking to the hair a little bit, and can be a symptom of dry eye, which we'll talk about in a moment. But a lot of clients will often say prior to coming to see me that maybe for the last few months you might have had a discharge that you've had to clean away every day. It's not that normal to have to clean a discharge away from an eye every day. It's not a normal thing to have to be doing. And some types of dry eye will start with this stringy mucoid discharge. And it's worth maybe mentioning that if you're popping into the vets for vaccinations or for just regular checks, if you're having to clean the eyes, it might be worth getting the tear film level checked. And I'll show you there now how to check. But that leads me to dry eyes. And these are eyes, which an eye condition that we see an awful lot of, and probably again in my top 5 conditions that I'll see in practice. There's lots of causes of dry eye, and actually humans have an awful lot of dry eye. I myself have dry eye. In dogs, the most common cause is something called immune-mediated dry eye. It means that the body decides it's going to start attacking the little cells which help produce your tear film. That's the most common cause, but there's lots of other causes. For example, like diabetes, having an endocrinopathy, a hormone issue, being diabetic, or having Cushing's disease, you can have a lowered level of tears in your eyes. There's neurogenic causes of dry eye, where the nerve that tells the glands what to do stops working. So there's lots of reasons why a dog can develop dry eye, but it often starts with a little bit of that sticky mucoid discharge. And we can see sort of in picture 1 there, just going to move everybody's faces out of the way so I can see. Picture 1 there has this green mucopurulent discharge on the surface. And particularly when we shine a light in our eyes, into our patient's eyes, we look at the reflection back of the light that we shine in. And you can see on the surface of that eye, it's an altered image. It's not a sharp image. And as we look at other pictures tonight of eyes, you'll see the defined flash of the camera. It's very sharp and in focus. And so this tells you that's the first layer of the eye that the light will interact with, will be refracted by, is the tear film. And so this is an altered Purkinje image, the surface of the eye. Picture 3 there, again, is another early stage of dry eye. You've got these little tiny vessels you can see on the surface of the cornea, on our windscreen, and that's that altered image as well. It doesn't look particularly sharp in the middle. And then picture 4 is a patient, again, who's chronic. Unfortunately, he's had dry eye for a while. He might have not responded, but this is an eye which that green discharge there, it's because he's had fluorescein put in his eye, which is a dye to check for ocular corneal ulceration. And again, if you've been to the ophthalmologist, some ophthalmologists will pop that in. Us as well, it's a human dye. But it checks to see if you've got any sign of ulcers. The surface of the cornea there is very rough and ready. It's a very red looking eye, and there's some vessels and what we call edema, that haziness across the surface too. So there's some changes there that need addressing. And then I suppose the lower left picture there, that's when dry eye gets really quite serious, and you've got a very deep circular ulcer there, where the surface of the eye, the windscreen, our cornea, has been unprotected for a long period of time. The tear film provides a lot of moisture for essentially a very dry structure of the cornea, but it keeps it moist and protects it. And so over time, a dry eye can eventually become a full thickness ulcer like this. And this chap here needs surgery to repair that. So the discharge you'll have varies. It can be just stringy to start with. It can become mucopurulent later. And early intervention is much better if you've got patients that we see like this. And there's many breeds affected. I'd say my top 5 breeds would be West Highland White Terriers, Cavaliers. I've seen a fair few Frenchies and Pugs, particularly with dry eye. But there's lots of other compounding factors that affect some of these breeds, not just the fact that they've got immune-mediated keratitis. And how do we check to see what's happening with our tear film? Well, maybe you've seen your vet do the picture on the left there. This is a Schirmer tear test strip. And it's a little strip that is measured in millimeters from the starting point right up to the end. And we pop this into the lower fornix of the eye. It has a little bit of dye impregnated near the 5 millimeter mark. And as your tear film is literally sucked up that little piece of essentially blotting paper, it takes with it the dye. And that tells us how many tears, how much in terms of tears per minute are you producing. And we're looking for a level of around 20 millimeters in a minute of that movement of dye. And this picks up reflex tear production. We do this without any local anesthetic in the eye, but it also picks up basal tear production and gives us an idea quantitatively whether or not a patient is producing enough in terms of tear film. The picture on the left is a different form of measuring our tear film, and this looks at the qualitative level of your tears. And I like to think of describing tear film as like a Mary Berry recipe. You need to have 3 different components of your tear film. One is called the mucin, and there's the aqueous, and there's a lipid. And you have to have those in the right levels in your tear film in order for your tear film to stick to the surface of the cornea and to stick together. So the test there on the left-hand side, this is a human, but it's a great video. And I use this to teach vets as well. We pop fluorescein, which we used a minute ago for ulceration, into the eye, and we ask the patient to blink once. And as you can see, over that, hopefully less than 20 seconds, you're seeing that that fluorescein is breaking up. It becomes dark in sort of C shape. You see that there? It's on a loop, this, so you can see what happens. But as it starts to break up, it tells us whether or not our tear film components of that recipe are there in sufficient quantities. Have you got a mucin problem, a lipid problem, an aqueous problem? And in dogs, normally a tear film that breaks up over about 20 seconds is normal. Anything sort of less than 10 is abnormal. So the faster it evaporates, essentially, the more likely you are to have an issue with the quality of your tear film. And you can have a 20 millimeter tear film, but a less than 10 breakup time. So it's interesting, a tear film keeps and protects the surface of the cornea. And moving on then to cases where we see ulceration, sometimes these are related to having had a poor tear film. So there's some pictures here now. Again, I'm sorry for those of us who are squeamish, of some ulceration. And this is probably my number 2 of conditions I see an awful lot of in dogs and cats. Here's a group of corneal ulcers, and they're all very different. We take this chap there on the left. This is a very, very deep ulcer in this eye. I think it was a boxer that had a really deep ulcer. The blue indicates the base of the ulcer, and an ulcer really is just where the windscreen has a large area of the surface taken off it. And this ulcer is greater than 50% of the thickness of that windscreen. So it's deeper than it should be. And that eye is like an aircraft at 35,000 feet. It's under pressure. It's making fluid inside all the time to keep it the turgidity that it is. And now that circular area in the center, maybe only 1 or 2 cells thick. So that's keeping the fluid inside the eye, but it's keeping the eye intact, and it's very in a dangerous, precarious position. The yellow arrow there indicates an inflammatory response that's gone on because of the surface of the eye was damaged. So that inflammatory response is a group, a cluster of inflammatory cells. You wouldn't be wrong in saying it looks like purulent looking cells, but it's something called hypopyon, and it's happened because of the surface of the eye has been disturbed. So that chap there on the left needs surgery, and at the bottom right, the 2 images there were of a pug. The image on the left is pre-surgery with an ulcer that was heading in the same direction as the one we've just talked about, and the image on the right is after surgery, and this is what's called a conjunctival pedicle graft. It repairs the area of ulceration. This is a view of the eye, probably taken about 4 to 5 weeks after surgery. So things are looking well. The other 2 pictures moving up to the top right, that's a cat that's had herpes virus. And you can see there a red arrow, the lower red arrow, that's a central ulcer on the surface of the cornea. And cats with herpes get a variety of different ocular syndromes related to herpes, but one of them can be these very deep ulcers, refractory ulcers, but a lot of conjunctivitis, the conjunctiva there, the red fluffy material around here is all angry as well. And if we look at the dog here at the top in the middle, this is an unusual type of ulcer, but we see a lot of these. This is a type of ulcer called a SCED, or superficial chronic corneal epithelial defects. So we call them SCEDs for short. Used to be, probably about 10 years ago, known as indolent ulcers or boxer ulcers, mainly because boxers were one of the breeds that we saw a lot with them. But any dog can get an indolent ulcer or SCED. And this is a special type of ulcer where you put the fluorescein in. You can see it's demarcated there by the green in the center. But in the edges of the ulcer are not adhered down properly. So the fluorescein goes into the surface and then sort of eases its way underneath the edge of the ulcer. And often these ulcers are way bigger than they actually appear when you look at them like this. And they take a little bit to heal them. They can be problematic, and most ulcers should heal within 4 days from start to finish if it's an uncomplicated ulcer like this. But the SCEDs can be notorious, and they can take sometimes several weeks. And there's a variety of different ways of treating them. But it's also worth having a little look and seeing if there's anything else causing the problem. And some ulcers which do take longer than 4 days, there might be something behind it. The upper left picture there, this is a patient that has distichia. These are extra lashes, and these are lashes in an abnormal place. They're coming out of little glands that are along the edge of the eyelid margin. They shouldn't be there. The glands should be there. They're helping to produce part of the tear film, but these little extra hairs are not, and they can be causing an ulcer. They can certainly be wicking tear film and cause more tearing sometimes in some patients as well. And on the right-hand side there, that arrow is pointing at what's called an ectopic cilia. That's a little hair which is completely in the wrong place. That's not coming from any gland. It's coming through the eyelid and is rubbing on the surface of the cornea. So if an ulcer is taking longer than about 4 days, I am mentioning to vets to have a look for the cause. It can be a tear film problem, but it can also be these extra hairs in the wrong place. I see lots of dogs with vision problems. This is a guide dog puppy. Look how good she is. and she was very good for, this is just me demonstrating what we do when we do an eye exam from a distance. And she was very well behaved. It took a few treats, but she didn't batter an eyelid. Now we normally do this in the dark, but we have a look from a distance, and we're looking, once we've assessed the dog neurologically, for any congenital abnormalities, inherited disorders, or acquired problems with vision. And we see this when we're looking. Now, this for me is perhaps the most beautiful thing you can see in dogs' eyes, is the back part of their eye. And every dog and every cat, and actually different species, have a different looking retina. And it's like looking, it's like opening a door if you've been trying to look through the keyhole and looking at the room beyond. And you see some very beautiful things when you're looking at the retina. Now, just to give you some idea of what we can see, that red arrow down the bottom, that's the optic nerve head, and that's where all the information from your retina, or the retinal ganglion cells, that's where the information kind of gets, what's the word? Congealed, coordinated, and then sent off up to the brain. And that's via the optic nerve. So the optic nerve head is the starting point of the optic nerve, and the optic nerve is one of your cranial nerves. It's the only place in the eye that you can actually visually see a cranial nerve in action. The vessels running dorsally to that, the ones with the black arrow there, they're the retinal vessels, and we're looking for the number of them, the size of them, their distribution. Do they look healthy? Is there any bleeding or coughing of them? Do they look normal? And this is a normal looking dog. We're looking then at the blue arrow, which is the tapetal region. I always think looks absolutely stunning in terms of color. And the tapetal region is a triangular shaped area in dogs and cats that has an area of reflective little crystals in one of the sandwich layers of the retina. The retina is 10 layers thick. These little reflective particles are right at the bottom of that sandwich. And so the reason that these guys have tapetal areas is so that light passes into the eye, goes through the first few layers of the retina, and then some of the light, some of the image that you can see, hits those reflective particles and is reflected back through the layers of the retina in front. And it allows a second pass of what you can see. So this is great for predator species. At nighttime, this is when they use this area particularly to give them an idea of, let's say, the mouse that just passed by, or what they might be wanting to eat of an evening. So this is a tapetal area, and can be a variety of colors in different breeds and in different dogs. Some dogs don't have a tapetal area, Siberian Huskies, for example, but every dog is different. And that's why I try and recommend to vets to look at as many eyes as you can, because if you think it's abnormal, it might be normal for that patient. Then just down the bottom, I suppose the more boring area, it's brown looking, and it's the white arrow at the bottom, and that's the non-tapetal region. It's non-reflective, just as important as any other, but the cells that pick up what you can see are spread across all of your retina, so all of it becomes very important. That's the dog, and this is the cat. So just to show you, I suppose, a difference, big old tapetal area there, the lovely reflection of the yellow and green. The non-tapetal region there is down the bottom, indicated by the white arrow. There's a little bit of reflection, that's just the blue arrow. So that's just to tell you that when we're taking these retinal photographs, sometimes you will get a bit of reflection off your camera, and that's nothing to worry about. And retinal vessels, the black lines there, and the red dorsally. Difference in cats is their optic nerve head is circular, in dogs it's triangular and often not myelinated. So they all look very different. But again, it's worth having a look at the back of their eyes. Well, this is what we can see. Beautiful pictures. And this is a human. So this is what all of us sitting at home, this is what our retinas hopefully look like. This is a healthy human. And you can see from this, we don't have a tapetal area. It's very boring looking, isn't it? But when I go to Specsavers or Vision Express, not to point out there's more than one that you can go and see, you can actually ask them if they take a photograph of your retina to go home with your retinal pictures. I'm sad I do that, but it's just to give you an idea. And we've got a circular looking optic nerve head there on the left, retinal vessels spread across in a different pattern to my patients. And then you've got this fovea, this sort of central area there. So very different looking fundi when you're looking at them. And when we are looking at the retina, this is sort of things we don't want to see. So retinal detachments is, again, probably maybe number 3 or 4 on the problems I see. And retinal detachments are where the lovely sandwich layers of the retina come away from the layers underneath. Not necessarily all synonymous with loss of vision, but certainly some patients will be blind when they present like this. And it can happen again for a variety of reasons. There can be infectious causes. In cats, we see this a lot with hypertension. So they get high blood pressure, normally secondary to something else, like having an overactive thyroid or cardiac disease, sometimes, or renal disease. And if you've got high blood pressure, then these tiny little vessels in the retina, they can't stand that high pressure for very long. And you will get bleeding within the retina, and the retina will sometimes detach. And unfortunately, they may become sort of visually impaired fairly quickly. This is a cat there in the central picture. You can see the tapetal region, but you can also see this area of hemorrhage above. It's hard to describe a retinal detachment on a 2D picture, but the retina folds up on itself, and we call them sort of on an ultrasound like seagull's wings. So if you look at the ultrasound image at the bottom there, it stays attached to the optic nerve head. That's the red arrow at the bottom. And then the 2 white arrows above that are the retina, which is actually floating now in the posterior chamber of the eye. And it does look like a seagull. So if you're seeing this sort of image on an ultrasound, you know that sadly the retina's come off. If you can get to the bottom of why it might have detached, you can actually try and get it to go back on. And certainly with cats, if they have a retinal detachment, if you can treat the reason behind it, you can get the retina to reattach within about 3 weeks, and they may get some vision back. So it happens in both cats and dogs that we see. Another rather sad retinal disease that I see a lot of in this country is progressive retinal atrophy. And there's a whole variety of breeds that are affected. It is an inherited condition. And in this dog, you might be able to see we've got our triangular optic nerve head down the bottom, retinal vessels, but these retinal vessels, they're attenuated. There's very few of them. They're there, but they're not looking big and chunky and healthy. And you'll get this hyper-reflectivity of the tapetal areas. So what happens is to our retinal sandwich, some of those layers get thinner, and the reflection really starts to increase. So sometimes you'll see a dog down the end of the garden and in a dim evening, and they'll look back at you as you call them to come back in the house. You might get this headlamp effect, and that's sometimes because their retina is getting thinner, so it's becoming more reflective. Sadly, there's no cure at the moment for progressive retinal atrophy. You can genetically test some lines to see whether or not they have the gene that may cause it, and not for everybody. And unfortunately, it can then lead on to other problems such as cataracts and glaucoma as well. And here's some cataracts for you. This is probably number 5 of my list of things that I'll see. And cataracts come in all different shapes and sizes and affect all different breeds. Again, there's a bunch of breeds that I see that have them as an inherited disorder, but they can be congenital as well. They don't have to be an inherited problem. Or they can be acquired through trauma, through insult, or through things like progressive retinal atrophy causing cataracts. And the lens is essentially a clear object. If I'm able to see through it, then a patient can see me. But these are different types of cataracts in different patients to a certain degree, and we do class them as incipient, immature, mature, hypermature, and then Morgagnian. So there's a few different classes of cataracts that we see in dogs and cats. And this is the same dog but different eyes. So it just shows you that cataracts can be different in different eyes in the same patient. This is a young pup and not great vision from birth. So these are likely to be congenital cataracts. And some are progressive, some stay very small and don't do anything at all. And some are progressive and cause problems with vision. So we can then talk about doing sometimes cataract surgery, and it depends on the patient as to whether or not we can. And you can have lens luxations as well. Again, I put this in because cataracts can change the density of the lens. The lens can become heavy, and fall. And this is a patient I've seen recently where the lens has fallen backwards into that posterior compartment of the eye. And so unfortunately this patient was blind, was visually impaired, and PRA had actually caused the cataract, and the lens had become so dense that it literally fallen backwards. You can have primary lens fixations, means you've got an inherited problem with how your lens is held in place. And we'll often see that in terrier breeds particularly. And now we'll end on a little bit of cataract surgery. So if anybody's squeamish or had the dinner or having the dinner, then probably look away now. But this is a short video on what happens when we do cataract surgery. This is cataract surgery in a dog. Not a very particularly dense cataract, but one that was certainly impeding vision, and a progressive one. When we're looking at cataracts, we're looking for vacuolation around the edge of the lens to see whether or not something is progressing. And nowadays, at the end of surgery, as we did with this one, we put in a intraocular lens inside the capsular bag. And essentially what we're doing at this point is removing the capsule of the top part of the lens. And we do surgery in a similar way to how humans have cataract surgery. So some of you may have had that already, but this is the similar procedure. And we use a similar instruments and similar machines to do cataract surgery in dogs as well. And then this is phacoemulsification. This is where the phacoemulsifier, which is essentially like a small needle which vibrates at 100,000 megahertz to shatter the lens into pieces, at the same time as aspirating the lens as well and irrigating, because you can imagine that level of vibration is going to actually create heat within the eye, and we don't want that. So it was also irrigating at the same time inside while we split the lens into pieces, into sections there. Some lenses are softer than others. Some are really quite hard. They're like concrete and you can't see through them. They're just brilliant white in their color. And certainly patients will be very blind with them, very visually impaired. This lens is breaking up nicely. Let's just speed up the video a little bit. Okay, so this is the end, and we're getting to the end of surgery now. And polishing, we've got rid of most of the cataract now, and there's just a few little end bits away. Just polishing the capsule just before putting in a foldable intraocular lens. And we don't need our patients to read the newspaper, but we do need them to be able to see well. And so this is a lens which is folded up, and as we inject it into the capsule of the eye, it expands as we do it. And so this sits in the line, the central line of vision, just before. I'm just going to reposition and then close. So that's cataract surgery in about 5 minutes. It takes a little bit longer to do, but just to show you. And this is a before and after surgery. These are two patients of mine. This is a hiccup on the left there. Both these guys were diabetic. He's had his left eye done, and you can just about see the cataract still in his right eye. We're still to do the right eye. That's the opacity there in the right as you look at it. And this is Björg. Björg on the right has had both her lenses done. So she's now visual and happy out. Surgery I love doing. So that in a nutshell is a little bit of ophthalmology. I hope I haven't put anybody off or disturbed anybody from the dinner.
Oh no, thank you very much indeed, Lisa. I have to compliment you on a very, very comprehensive presentation. My goodness, you've covered a terrific lot of issues that, I think probably we've all come across at some stage or another. And I had my dinner, so that's okay. Actually, I was interested at the start when you said you were up at photo with the lemurs, looking at their eyes too. That must be a challenge.
It is. They often they bring them down. There's a lemur there with cataracts actually, and we've been talking about doing surgery on her because from a behavioural point of view, they'd be getting they can pick on each other, and certainly some of the I suppose the troop type animals would sense if another animal isn't quite right, and she'd been having problems getting her food and things. So she's actually she's improved on topical medication at the moment, so we're holding off doing surgery. But it's very interesting to examine them. I have to have a little bit of sedation to do it, just so I don't lose my fingertips. So
Oh, I could imagine. They're a lovely looking creature. Actually, their eyes always fascinate me because they're like spotlights, aren't they? The lemur eyes. They're
they're very similar
very
to
unique,
human
aren't
eyes.
they?
Yeah, very similar. The primates are very similar to human eyes, the human globes and the retinas. They're very similar. And
I mean, if they were dogs, as a judge, I'm afraid I'd have to probably put them last in the class because of those big light eyes. I'll just run through some of these questions. Do you need to sedate the dogs for examination? I know we saw you looking at a guide dog there, but without any problem.
No, I have to say, I can't remember the last time I did, and we try not to. It can alter some of the results. One of the things we didn't mention was glaucoma, but when we check their intraocular pressure, and if you imagine sitting at the ophthalmologist and you got your chin and you get that little puff of air,
I do,
that's them measuring your intraocular pressure. Now, we don't use the little puff of air, but we use what's called an applanation tonometer with dogs, which we put local anesthetic in, they can't feel me, and we just very gently applanate the surface of the cornea to measure their pressure. Sedating them alters some of these readings, so we definitely try not to. It would alter your tear film level, it will reduce it, and any animal having an anesthetic for 48 hours after an anesthetic for anything will have a lowered tear film. So it just shows you that those things can be changed. And so to get an impression of what that patient's actually going through, no, we don't sedate them. No.
Yeah, it's amazing how good they are, really, you know, kind of knowing what we're like if somebody trying to put something in our eye. Now, another question, ingrown eyelashes, can you operate to fix them?
You can. It depends on if we're talking about distichia.
Funny, I was going to ask you about distichia, which would probably come into this question as well. I was actually going to ask you, do you consider it a hereditary problem? And also, is there a permanent solution to them?
I think, yes, it's hereditary, and I see it in a lot of lines of different breeds. Is there a permanent solution? It depends really on the severity. Yes, there is, but it depends on the severity of the distichia. Some dogs will have one or two and will be good enough to maybe let you epilate them, you know, to just simply pluck them. And some will have many. And each of the meibomian glands, the glands along the edge of the eyelid, there's about 30 to 40 glands per lid. So each one of those has the potential to produce a hair, a distichia. But not only that, if a hair comes through, you can get several hairs coming through one gland and literally like tufts. And those guys, absolutely, surgery is warranted, because if they're rubbing on the surface of the eye and causing pathology, you can imagine it's probably quite uncomfortable.
Oh, horrible.
Yeah, and it can cause this tear staining here too, and ocular ulceration and wicking of the tears. So some dogs get like almost like a dermatitis below here too. So you can do things like cryotherapy and actually freeze individual meibomian glands. You will get some change sometimes in the pigmentation of the lid margin. If they're a dark dog, you might get a little white spot where you've been, but you won't get any hairs back. You can do electroepilation. That tends to be the thing I do, where we put in a tiny little needle into each of the meibomian glands and pass a current through them and literally zap the hair follicle so it doesn't produce another hair. And in very severe cases, you can actually do lid margin surgery. We try not to do that. I like the apposition of the lids as they are, and any kind of lid surgery is going to change that and change how you blink. But it depends on the severity of the patient, really.
Yeah, but it is definitely hereditary.
Yes. Yeah.
What sort of, I mean, obviously being a poodle breeder, I've seen it in poodles. What other, are there other breeds that it is prevalent in?
I see it in poodles a lot. I see it in rough collies a fair bit, Labradors. There's some lines that the guide dogs are just keeping an eye on, with the odd little one appearing. But yeah, those would be maybe the top three breeds. But honestly, anybody can get distichia. Doesn't necessarily have to be one of the main ones, but those would be maybe my top three.
Yeah, and also, I suppose, and again, maybe in the same role of inherited, which I presume inherited things are like entropion and ectropion. You can operate on those, I presume, okay?
Yes, for entropion, ectropion, yeah, absolutely. And there's a whole variety of different procedures depending on where the disorder is. For example, the Bernese Mountain Dog that might have what we call diamond eye, or Dog de Bordeaux that I see a lot of with diamond eye, where they're ectropic in the middle, the central part of the lower lid, and they might have entropion towards the lateral part, and they sometimes don't just need the lid bit doing, but also there's a ligament here called the lateral canthal ligament that needs stabilizing in order to make what you do successful, right through to things like Sharpays. I see a few Sharpays, not many in this country, but they've often got entropion based on their head position. They can have bad entropion anyway, all the way around where the lids are rolling in onto the eye. But they're much worse if they've had their head down. Of course, everybody feeds their dogs mainly on the floor. So they're putting their head down and their whole facial mask and all those lovely rolls of skin falls forward, which makes their entropion worse at different times of the day. So yeah, there's lots of surgery you can do, but it depends again on severity and breed to a certain degree.
Yeah, obviously, as well, I mean, as a breeder with the poodles now, the best thing is try not to breed from anything that's infected with anything like that. Thankfully, it's only very, very occasional. Now, I have one here. My Labrador puppy, aged 5 months, last had an eye infection. She was treated with steroid drops. Infection is back after 2.5 weeks. Doesn't say what it was diagnosed with, but
yeah, it's young to be having eye infections. It could just be, it could be anything really. And I get lots of questions like that. Can you diagnose this from a photograph? And it might be an ear because they've shot past you. You try to take a picture. It could be anything at 5 months. It could be a simple conjunctivitis, but this is personally now, I'm not a fan of steroid drops unless you've got intraocular issues. And if something has come back, your next step is go back to your vet and have a chat with them about maybe doing some swabs or sampling or just something further, because it can be not necessarily that it's not gone away, but is the cause still there? So it's worth investigating, particularly if you're getting recurrent problems.
Thank you. Now, with so many DNA tests available for various eye conditions, PRA, OSD, etc., for example, how do we encourage breeders and puppy buyers to use these tests to avoid breeding these problems? I presume what this person's getting at is, okay, the established breeders kind of know about these things and test, but how do you get the maybe the pet buyer or to be aware of all these different things?
You know, it's really hard, and like we were talking earlier, I think it's about education. But there's definitely pros to doing it, and to obviously through lines getting rid of breeding problems that way. It's certainly the way to go for lots of breeds that have inherited disorders. It's not foolproof, I would say, in that I'm just thinking of a recent case I've had there of an Australian Labradoodle that's most definitely got PRA at age like 5 or 6, and that dog wasn't tested themselves, but the parents were, the grandparents were, for PRA. And the problem is that it's worth bearing in mind that every genetic test is not 100% guaranteed. For example, I think probably in this particular case, yes, everybody else was negative for PRA, but we're testing for a gene locus, a place on a gene that we know creates, let's say, a line of PRA. And it's not improbable to have a marker for PRA that's somewhere else. And if we don't have a test for that place, then when you're testing, your pet will come back as negative. But it doesn't mean to say it's not there. Does that make sense, Em?
Yeah.
And so I definitely encourage doing it, but it has to be taken with a little pinch of salt, that it's not 100% foolproof.
I think part of the problem now too is that I'm saying show breeders, but I'm kind of I'm using the word professional breeders, and I'm not using the word in that money making, because usually it isn't when you do it correctly, are very aware of the tests, and you know, you don't breed from anything that has a problem. I think it's a problem now that there's a lot of people out there that are totally unregulated and don't bother with any of the tests. And
I know, and I think it's filtering down. I certainly personally have seen an explosion of people getting dogs, puppies and things since COVID started.
I'm sure, yeah.
An explosion. And certainly colleagues of mine would say the same. Some are vaccinated, some aren't, some are microchipped, some aren't. It's very hit and miss.
Yeah.
Genetic testing seems way down the line for a lot of these breeders. And I think in the next few years, we'll see the problems associated with what's gone on in the last 12 months come to the forefront, sadly, because of that. And I don't think the general, I don't think generally we're putting it out there. I don't know if it's at shows and things test. I don't know if you see that. And do you see any of the like Optogen coming to shows to promote?
Well, we don't, but as breeders and breed clubs and so forth, you see, we would all be very aware of that. But then once you go outside that, and as you just kind of said, the market for puppies is so high now.
That's colossal. Yeah.
They're just breeding dogs willy-nilly without any consideration to, and it's hard to get the word out there. That's the problem, and to buyers. I just got a message through. Yes, that puppy that we were saying about the steroids, it was conjunctivitis. So that was it. When a dog is tested unaffected for its annual eye test for 3 years, and then it is HC affected for its 4th test, how does that happen?
Because it certainly depends on the breed, but certainly not all cataracts appear at an early stage, and some can be clear. Sometimes you'll obviously, you can, like I was saying about different cataracts, you can get different reasons behind cataracts. So sometimes you can have them appear because you've got a secondary problem somewhere else. So it is possible to have a cataract appear later on, but that's why we check them on a regular basis. You know, that's why they have the annual tests, to make sure that nothing has developed since.
Yeah, of course, and thankfully there's DNA testing now available for a lot of things as well, but nothing is foolproof. I don't know whether this is a question you can answer. What's the average distance a dog or a cat can see? Can a cat see further than a dog?
No, I went to a really good a month-long course in the States, in Madison, Wisconsin, and the guy who invented LASIK surgery was there. He came and lectured us. Interestingly, he said he wouldn't have the surgery, so I'm never going to have the surgery. He's not going to recommend it. But he discussed being hyperopic and myopic, so long and short-sighted. And just as we can be, I'm very short-sighted, so can animals. But the problem is it's very difficult to refract animals and to say, look, can you read the Snellen chart and what can you see? So it's very hard to do that, and quite subjective. Even different ophthalmologists will try and refract a patient and disagree. So it's not something I do, because I think it doesn't change an awful lot of things, but it does sometimes explain why a dog can't see particularly far away or close up if you've done all the other tests.
Yeah.
No other reason why. When we put in an intraocular lens after cataract surgery, we put it into as near as we can. It's a 40 diopter lens to what we think they'll be able to see. They're often left a little bit long-sighted after cataract surgery. But yeah, that's a good question.
Best age to test for APD, and how often would you test?
I'd probably say 12 to 18 months or thereabouts, and yearly, you know.
Any treatment to help prevent eye staining? I think that's a very common problem, isn't it, with light-colored dogs?
If I had €1 for every person who asks me, no, you can, because tears have what's called porphyrins in them, and porphyrins are stains. It's also, porphyrins are in saliva too, so often dogs that have tear staining, you'll find that they've got sort of saliva staining, and it's more obvious in the creams and the whites breeds of dogs. There's lots online. You could probably buy shark's fin, dandelion root, all kinds of stuff. Doesn't work. Waste of money. The only thing that actually changes the level of porphyrins is actually an antibiotic called doxycycline, but you can't be on antibiotics, forever. I certainly wouldn't promote that. But that's the only thing that changes the porphyrin level. You can cleanse. There's a solution called Ocral cleanser, and that claims, that's a veterinary product, and they claim that that does reduce the amount of tear staining. I do use it in my patients, like that Westie with the sticky discharge. I would use that fair amount. I've yet to see whether or not it reduces tear staining, but honestly, I don't think you can do that much about it.
I think if somebody invented a product that would clear that up.
I don't know. I think next time you get a brown dog.
Is there any connection with ear infections in eyes? Or can ear infections cause a problem with
It can, neurologically, yeah. Not as in a close contact thing, but if you get a middle ear infection, the middle ear in all dogs and cats is a bony area where the facial nerve runs through, and nerves which control what your eyelid does, whether or not you can blink, whether or not your pupil is small or big. And those nerves run through the middle ear. So if you've got particularly a chronic middle ear infection, you can sometimes find the patient doesn't blink properly, and might then get ulceration because they can't spread their tear film. And there's a condition called Horner's syndrome that can be related to middle ear as well. So neurologically speaking, they tend to affect each other, but not normally through infecting locally.
I think that's, Gerald, unless you got any more questions coming through, I think that we're at the end of our questions. Sorry, I can almost talk. And look, thank you very much indeed. It's been such an informative evening. It really has. And I think you covered an amazing territory over it all. I really do. And it's great to know that you now have the clinic on our doorstep, really is. So I think you might find you'll have a few more people beating their way to your surgery door. So thank you very much indeed. It's greatly appreciated, it really is. So we'll end the evening. Good night, everybody, and thank you for joining us. And remember, Pet Eye Vet Clinic if you have any issues. Good night.
Thank you.
Good night, everybody.